This is a recording for Chapter 16, Depressive Disorders. So, symptoms of depression have been described almost as far back as there's written evidence of documentation. The occasional feeling of sadness or downheartedness is common in healthy people and considered to be a normal response to everyday disappointments in life. Pathological depression occurs when adaptation is ineffective and the symptoms are significant enough to impair functioning. Um, Mood is a pervasive and sustained emotion that may have major influences on a person's perception of the world. This could be depression, joy, elation, anger, anxiety. And affect is the external, observable emotional reaction associated with any experience. Depression is an alteration in mood that is expressed by feelings of sadness, despair, pessimism. There's a loss of interest in the usual activities, and somatic symptoms may be evident. Changes in appetite, sleep pattern, and cognition are common. A note here in older people, sometimes we see behavior changes and um, loss of appetite, things like that, changes in cognition, and we assume they have dementia. Before we diagnose anyone with dementia, we need to rule out that they have depression. So, major depressive disorder is one of the leading causes of disability in the United States. Lifetime prevalence is about 21%. Um, there's evidence of the incidence of depression is increasing among teens, young adults, and particularly in adolescent girls. Teens 12 to 17 years have reported having at least one major depressive episode in the last year, and 11% of those have had a severe impairment for over a year. Teens with depression are more likely than others to use substances, and there is a correlation between that and increasing suicide risks in teens, which is a major public health issue. Depression is more prevalent in women than men. Lifetime prevalence of depressive disorders is higher in those who are 45 years of age and younger. Um, it's hard to pinpoint a single age correlation because many factors influence age-related depressive symptoms. The statistic of more men than women is almost universal, independent of the country or culture. After 65, uh, women continue to have more depression than men. Um, there is some biological explanations to this. Women have a higher concentration of monoamine oxidase, which is a neurotransmitter associated with depression. Um, More likely to have thyroid dysfunction and hormonal changes that occur during menstrual cycles, postpartum, and at menopause. Psychological factors may also contribute, and women may have an increased sensitivity to stress, multiple different social rules, and poor coping mechanisms. Single and divorced people more likely to have depression than married people or people who are in a long-term relationship. Um, Studies aren't sure why this is, and they don't think that marital status alone is um, an indicator. Some studies say that age is as important a variable um, among both married and single people, and marital stress has been associated with an increased risk for depression, suggesting that social stress may also be very important to consider when looking at statistics of depression. Seasonality affective disorders are more prevalent in the fall and the winter. Seasonal affective disorder is a disorder that has a seasonal pattern. Um, whether all depressions have a seasonal pattern, um, studies have shown there was no evidence of seasonal pattern for major depressive disorder, but people with affective seasonal affective disorder or SAD are more likely to have um, depression in the winter months. Major depressive disorder characterized by depressed mood, loss of interest or pleasure in usual activities, impaired social and occupational functioning that has existed for at least 2 weeks, no history of mania, and symptoms can't be attributed to any use of substance or a general medical condition. Diagnosis will um, talk about the degree of symptoms, whether they be mild, moderate, or severe, and whether there is evidence of psychosis, catatonia, or melancholic features. Dysthymia, persistent depressive disorder, feeling sad or down in the dumps, no psychosis, milder than major depressive disorder. There is no psychotic features, and the essential feature is that the person is chronically depressed for most of the day, more days than not, and at least 2 years. Early onset is considered before the age of 21. Late onset is 21 and older. Premenstrual, premenstrual dysphoric disorder. That is dysphoric mood that is related to the menstrual cycle. Depressed mood, excessive anxiety, mood swings, decreased activity in the week prior to menses, improving shortly after the onset, and becoming minimal or absent after in the week post menses. Substance or medication induced depressive disorder. The depressed mood is associated with intoxication or withdrawal from substances such as alcohol, amphetamines, cocaine, hallucinogens, opiates, sedatives, hypnotics, or anxiety medications. The symptoms meet all the full criteria for depressive disorder. There are other medical medications that also can cause um, mood symptoms, anesthesias, ana- analgesics, anticonvulsants, antihypertensives, cardiac meds, muscle relaxants, sulfonamides, steroids. Depressive disorders may also be um, associated with another medical condition. It may be a direct consequence of that medical condition, and it must clinically cause distress or impairment in social, occupational, or other important areas of functioning like major depression. Why do people get depressed? Um, Cause is unclear, like many of the um, psychotic disorders. There's a lot of theories, and we have evidence, but there aren't really one clear thing that you can say, aha, this is what causes it. Evidence looks like there is multiple causes of depression. Um, there is a genetic link that has been found. Family studies found that major depression is more common among first degree biological relatives with the disorder than the general population. They may be related to a deficiency of the neurotransmitters norepinephrine, serotonin, and dopamine at the important receptor sites in the brain, and also possibly acetylcholine um, that has been recently added to the list there. Cholinergic agents have profound effects on mood, sleep, and neuroendocrine function. It has been suggested that the problem in depression and mania may be an imbalance between biogenic amines and acetylcholine. Neuroendocrine disturbances, um, hormonal factors, um, thy- thyroid thyrotropine releasing factor from the hypothalamus that stimulates the release of TSH, thyroid stimulating hormone, from the anterior pituitary gland. Diminish TSH response appears in about 25% of depressed people and seems to be associated with an increase for relapse despite treatment. A number of drugs, either alone or in combination with other medications, can produce a depressive syndrome. Most of these common drugs have a direct effect on the central nervous system. An individual who has had a CVA, brain tumors, particularly in the temporal lobe, Alzheimer's disease, Parkinson's, Huntington's disease, or MS may display symptoms of depression along with those illnesses. Excessive levels of sodium bicarbonate or calcium can produce symptoms of depression, as can deficits in magnesium and sodium. Potassium is also implicated in depression. Psychoanalytic theories. Freud had a lot of thoughts about what might have caused depression or melancholy. Um, he said that the depressed patient's rage is internalized. Um, a lot of these theories have been pretty well debunked over the years, and because his were more about relationships, parenting, those kind of things. Learned helplessness predisposes a person by imposing the feeling of a lack of control over their life situation. It was believed that people became depressed because they feel helpless and they have learned whatever they do is futile. Um, those are some psychosocial theories that possibly might contribute to depression. The theory of object loss um, suggests that depressive illness occurs as a result of being abandoned by or otherwise separated from a significant other during the first 6 months of life. The lack of attachment, which may be either physical or emotional, leads to helplessness and despair and contributes to lifelong patterns of depression in response to loss. We do know that those first, Erickson's first um, stages are very important, and there may be mental issues that arise from not being able to meet those milestones. And the first milestone is um, not forming a trusting relationship with a significant other. Usually we think of that as the mother, but it could be another caregiver. And another theory is that the primary disturbance in depression is cognitive rather than affective. The underlying cause of depression is cognitive cognitive distortions that result in negative, defeated attitudes. Um, these distortions arise out of a defect in cognitive development, and the individual feels inadequate, worthless, and rejected by others. Their outlook of the future is one of pessimism and hopelessness. And this is one of the theories that we um, look at when we talk about cognitive behavioral therapy, how to take the thoughts and feelings that a person has and from the negative and visit them in a positive manner. Um, the model of stress and adaptation says that there are multiple effects that are causing depression, which is probably the most um, realistic one. Depression, along with dementia, is one of the most common psychiatric illnesses among the elderly. Um, the estimates are that 1% to 5% of older adults living in the community have depression, but this increases to about 13% for those who are living in a nursing home or older adults who are hospitalized. That is statistics from the CDC. Depression is also more common in older adults who have other medical conditions and those with functional limitations. Um, Depression among the elderly may also be um, influenced by society. Society places a lot of value on youth, vigor, and productivity, and the societal attitudes reinforce that idea of low self-esteem and helplessness and hopelessness that become more pervasive as you advance in age. Um, Aging persons may adaptive coping skills may be challenged by physical problems, financial problems, change in bodily functioning, or an increased awareness of approaching death. Um, Problem is made worse by losses such as a spouse, friend, independence, their home. It's called a bereavement overload when individuals experience so many losses in their lives that they're not able to resolve one grief response before another one begins. This is especially true in older individuals in depressive illness. Although the elderly make up only a small proportion of the population in the United States, the suicide rates for the elderly are higher, especially among older white men, which I think we talked about in Chapter 11. Symptoms of depression are fairly um, similar to younger people. Uh, However, sometimes depressive symptoms are confused with other aging um, illnesses. And I talked about that, I think, earlier in this, that we need to make sure an elderly person who has a new onset of dementia, that we look at them for depression, memory loss, confused thinking, um, being apathetic, may be the result of depression and not dementia. Many medications that the elderly use also can have a depressant effect. Many of the illnesses that affect older people, such as cancer, arthritis, Parkinson's, also have a symptom of depression. Treating the depression in these situations can help individuals cope with those medical problems that they have. The most effective treatment for depression in elderly is thought to be a combination of psychosocial approaches and biological approaches. Antidepressants medications are administered um, by, and these are administered by keeping a thought on how the elderly body works, to make sure that the medications may not reach high levels, even in smaller doses, because of the decreased effectiveness of our liver and breaking things down, and our kidneys of excreting them as we get older. Anticholinergic side effects can also be a problem because they can cause falls and other things like that. ECT treatment is an alternative for the elderly, especially if they're unable to be able to deal with the side effects of antidepressant medications. It's been shown to be therapeutic. Um, it's highly safe, highly effective, and well tolerated in the geriatric population, um, shown by research. It may be the treatment of choice for an elderly individual who is acutely suicidal or unable to tolerate the antidepressant medications. Confusion, which is a side effect of ECT, typically does not last very long and is generally more pronounced in the elderly, but usually it is not a long lasting. Other therapeutic approaches, interpersonal, behavioral, cognitive, group, and family psychotherapies. Um, Appropriately treating elderly people for depression can bring them a new lease on life, and they may feel much more renewed and productive after treatment. Then there's postpartum depression. This may last from a few weeks until for or several months, and it's associated with hormonal changes, tryptophan metabolism, or cell alterations. It can vary from feeling the blues to moderate depression to severe depression with psychotic features. About 50% of these episodes actually begin prior to delivery. Um, the onset of symptoms during pregnancy increases the risk for postpartum major depressive disorder. Um, Major depression with psychotic features occurs in about 1 to 2% of 1,000 postpartum women. This includes worry, sadness, fatigue after having the baby. Um, these symptoms affect about 80% of mothers, but they usually would subside in a week or two, um, unless it moves on to postpartum depression. Postpartum psychosis, we need to identify the possibility of suicidal or harm to others in these um, patients. some symptoms that you'll see in postpartum depression on this slide. Transient depression, um, affective, the blues, behavioral, some crying, cognitive, difficulty getting one's mind off one's disappointments, and physiological, feeling tired and listless. These are symptoms of transient depression. It subsides quickly, and the individual is then able to refocus. Um, Mild depression, um, these are the symptoms: anger, aggression, tearful regression, preoccupied with loss, loss of appetite, not being able to sleep. Moderate depression with a dysthymic disorder, feeling helpless, powerless, slowed movements, slump posture, limited verbalization, uh, difficulty in thinking, problems concentrating, either anorexia or overeating, sleep disturbance, either sleeping too much or too little, and having headaches or other physical symptoms. Severe depression um, includes major depression and bipolar depression, um, feelings of despair, worthlessness, flat affect, psychomotor retardation, lack of communication, possible delusional thinking with delusion of persecution, somatic delusions related to aches and pains and illness, confusion, suicidal thought, and a general slowdown of the entire body. Risk for suicide is one of the nursing diagnoses that we need to look at. Complicated grieving, real or perceived loss, or having a bereavement overload. Too many things happening in too short a period of time. I think we talked about bereavement overload in another slide. Low self-esteem is another one. Powerlessness and spiritual distress. Um, Complicated grieving, anger towards God, a loss of a loved one um, can cause the person to kind of lose the faith that they have in religion, feel angry that God allowed this to happen. Social isolation, impaired social interaction is another nursing diagnosis you may see. Disturbed thought processes, withdrawing, imbalanced nutrition, less than body requirements. You might also see imbalanced nutrition more than body requirements, insomnia or hypersomnia, self-care deficit. Outcomes. We want them to have experienced no physical harm to themselves, um, discuss their feelings with staff and family members, express hopefulness, being able to set realistic goals for self, um, is able to participate in activities, and able to identify aspects of self-control over their life situation. Personal satisfaction and support from spiritual practices that would depend on the person's spiritual beliefs, interacts with others willingly and appropriately, um, orientated to reality, is able to concentrate, reason, problem solve, eats a well-balanced diet, and is able to sleep. Risk for suicide. We talked about this a little bit. Being direct, encouraging the verbalization of feelings, and maintaining close observation. For complicated grieving, nurse-patient relationship, encourage the person to express the emotions that they have. Low self-esteem, self-care deficit, be accepting of the patient. Um, Encourage them to recognize what areas they need to change and encourage their independence in ADLs. Um, Self-care deficit is defined as the impaired ability to perform or complete activities of daily living. Someone who is very depressed may does not have the energy to do these kind of things. If they can't do them themselves, they should be assisted with the ADLs um, and encouraged to continue and to do the ADLs because everybody feels better when they have brushed their teeth and taken a bath and all those kind of things. So if they need a little help with that or prompting, that can be helpful to helping them feel better. Um, Promoting group therapy, teaching them how to be assertive, and uh, teaching them activities that they may be having difficulties with. Powerlessness, li- um, the lived experience and the lack of control over a situation, including a perception that one's actions do not significantly affect an outcome. Um, we need to help the client to participate in decision making regarding their own care, um, problem solve ways to take control of their life, and encourage the client to take as much responsibility as possible for their own self-care and to set realistic goals for themselves. Education, we need to teach about depression, client and family. A lot of families have a hard time understanding um, depression. Um, I was depressed yesterday, but I feel better today. If you haven't had major depression, it sometimes is very hard for family members to understand and be supportive of their person who is depressed. So we need to teach both the client and the family what depression is and why does it happen and what symptoms they may see. Management of the illness, medication management, assertive techniques, stress management techniques, things to increase your self-esteem, and again, electroconvulsive therapy. Suicide hotlines, support groups, legal financial assistance. And we evaluate this, the interventions. Has self-harm been avoided? No suicidal ideations? Does the patient know how to seek assistance and where to go if suicidal thoughts do occur? And has the client discussed recent loss with family members and staff? Um, Again, the safety plan. Um, Getting all this put together. How did I feel when this started? What can I do if I see these symptoms coming again? Who do I call? Who do I talk to? What do I do? Those kind of things. Um, is the client able to verbalize the feelings and behaviors? Um, do they have realistic goals for themselves? Are they able to verbalize positive aspects about themselves, their past accomplishments, their future prospects? And can they identify what areas of their life situation over which they have control? And are they able to participate in religious practices that were previously satisfactory and support for them? Um, can they interact with others in an appropriate manner? Is there any evidence of delusional thinking, or are they able to maintain reality orientation, Can they concentrate? Can they make decisions? Are they eating enough? Um, not too much? Are they able to sleep an appropriate number of hours? Are they able to attend to their personal hygiene? And are their somatic complaints subsided? Things that were not like headaches and aches and pains and things like that that were a symptom of the depression. So therapy, individual psychotherapy can be helpful, um, or it can be with a group. Family therapy may be appropriate depending on the situation. And then cognitive behavioral therapy can be very helpful to um, look at thought distortions and consider um, how they can maintain their mood and how they can look at things um, objectively rather than using dysfunctional patterns of thinking. Electroconvulsive therapy, we've talked about this a couple times. You also have a video um, that is fairly recent with some patients talking about their experiences with ECT. ECT is done, it's kind of like an outpatient surgery. So the person is medically cleared for this. They do get IV medications. They get a muscle relaxant. So they do need artificial airway support for a very short time. There are risks, but usually the biggest thing is some temporary memory loss and a little confusion right after they wake up. It doesn't usually last very long. Um, the video will show you the difference between unipolar and bipolar um, treatments, and unipolar seems to have less memory issues than um, bipolar. So take a look at that video. Transcranial magnetic stimulation. So that's a procedure that is done by stimulating nerve cells in the brain. It uses short pulses of magnetic injury to stimulate nerve cells in the cerebral cortex. And it is similar to the electrical activity that is seen when ECT is done. They do not cause a seizure, unlike ECT. It's non-invasive and considered generally safe. Vagal nerve stimulation um, involves implanting an electronic device in the skin to stimulate the vagus nerve. Don't really know why this works, but people with chronic recurrent depression have improved when they have had this stimulator. And so there's still trials going on to determine the effectiveness of that. Deep vein stimulation, an electrode is implanted with the intent of stimulating brain function. This procedure, a deep implant, requires a craniotomy. It is reserved for patients who have severe incapacitating depression or obsessive compulsive disorder. Light therapy has been shown to be effective treatment for seasonal affective disorder. There's a light box which patients can use at home that is used for a certain period of time, and they are exposed to light. They can do this at home. Um, is believed to be related to retinal stimulation, which triggers the reduction of melatonin and increases serotonin in the brain. Antidepressant medication is usually the first line of treatment for severe depression, but also used in other depressive disorders. There are tricyclics, SSRIs, um, SNRIs, um, and a whole bunch of other types, MAOIs. There are safety issues with all of these, um, and some of these antidepressant medicines can be lethal in an overdose. So, if you have a suicidal depressed patient, they need to be observed closely. And I think we talked in the suicide one that they may be given only a short um, prescription for their medications, that they need to get filled more frequently so they don't have enough medications that they can overdose on these. Tricyclics are especially dangerous for that. We want them to take the medications for at least 4 weeks. If there's not a therapeutic response within those 4 weeks, then they may need to change medications. Don't discontinue them abruptly. And then uh, things to report to their doctor if these happen. Those are kind of general things. Now, if they're taking the MAOIs, and MAOIs are not given very often because they do have some um, serious side effects, and they have a very limited diet here. You have to be on an MAOI diet in order to take these medications. Not following the diet can cause um, a hypertensive crisis, which can be a fatal side effect of this, life threatening, anyhow. So there's a list here of things: aged cheese, wine, beer, chocolate, coffee, tea, smoked meats, canned figs, um, raisins, yeast products. I tell people to think no pizza, no beer. Um, Over the counter medications also. And there are some MAOIs that are not psychiatric medications. So if you look on a lot of the over-the-counter medications, you'll see that there is a warning that if you're taking MAOIs, that you should not take this medication. Cold medicines, diet pills. Um, 30 to 50% of people do not respond to the first antidepressant prescription. So there is possible to do genotyping, and there you can take a blood sample and it will give you a readout of which medications are more likely to work for you dependent on your genotype. I haven't seen this a lot in adults, but in children, um, I've seen a lot of children doing genotyping to decide which type of medication would be the most helpful for them, um, simply to um, prevent having to go from medication to medication to medication.